Yeah, and as I said earlier, put in your name and organization and role in the chat, and also for your name in the Zoom square, put if you're a HVAC member, a guest, DCYF staff, or TRIO member after your name. And let us know if you need help with that. All right, next slide, please. Okay, so I'm just going to run through some housekeeping for the meeting and get us started. Talk about our role and our values and what we're here for. So the role of this advisory committee is to integrate the expertise of home visiting models, early learning research and knowledge, and the experience of families and providers to inform how the state supports and expands home visiting services. We also develop strategies and recommendations on how home visiting can be more integrated and accessible with other community resources, and review and discuss and deliberate to shape recommendations on key questions and findings based on data and research. So the role of TRIO staff in HVAC, you can see here: attend HVAC meetings as an observer, provide professional guidance when asked, hold input until HVAC members and public have had a chance to speak, and then policy and decision concerns and questions we can direct to Laura, Nellie, or Nicole, and that can be via chat or email. And then if you are a public attendee, we welcome you. We're happy to have you here. And the guidelines for public attendees are that only HVAC members can vote or respond to polls, save comments and questions for the public portion of the meeting. And then any technical difficulties you have, please reach out via private message, and we're here to support you with that. Yeah, now I want to go over our values, and I love that we start with this and review it at every meeting. I think it helps us stay grounded and focused on the work we're doing. So our values are that we have a portfolio approach. We want diverse representation. We want to fund a range of capacity, and we value local implementing agency participation. Our goals are to ensure access to home visiting services for families that could benefit most in Washington State, establish consistent and effective process to gather feedback from stakeholders regarding home visiting, and advise leadership regarding home visiting direction. We utilize data to understand community need and disperse funding to communities that could benefit most. And we support home visiting services in being integrated and accessible in communities so that families can get the services they need. And I'm going to turn it over to Nellie.
Good morning, everybody. Welcome again. Just wanted to go over our agenda here briefly. I am hoping that you received it about a week ago. So we are going to spend some of our time doing a legislative update. We'll have that available for us today. We will have two presenters who will walk us through the 2025 maternal mortality review report and recommendations. We're excited to have them today and to spend some time there. Then we have a variety of DCYF updates. Some of it is a follow-up to our conversation around the expansion and also conversation around the utilization of funds from our underspend. So we'll spend a little bit of time there and some other updates around McVie. And then we'll spend some time as a committee talking about HVAC membership. We want to follow up on the initial conversation we started last time we connected around lived experience experts. And then we will close our time together. So there may be some shifting around of the agenda as we kind of get into it, or we may kind of need to adjust things. So this is kind of our plan for today, and we'll just have some flexibility around how things work out. So we have also two of our kind of regular HVAC attendees. One is an HVAC member who has retired. So Jill Smith retired last Friday, and she sent a message to the entire committee. And this is just a snippet from that. So just wanted to take a moment. I know that she is not here with us, but to just take a moment to acknowledge um, that she was a part of HVAC and she contributed. And she it sounds like she is on to other more kind of exciting things. And so we're excited about that for her. And then Nina Evers will be retiring here in the next month or so. And Nina has been part of the home visiting team for 9 years. And so just wanted to take a moment real quick to just identify and identify that this is Nina's last meeting. Jill's last meeting was in February, and just wanted to take a moment. And again, thank them both for the contributions that they've made to HVAC and to their roles beyond HVAC. Okay. And I'm going to transition this over to Nina.
Thank you, Nellie, and thank you for all the hearts. Very much appreciated. And I was invited to do the community related, the relationship building part of the program today. And I have a simple question that I'm going to ask for us for breakout groups. And but first, I just wanted to say that I wish a routine of mine was to regularly express gratitude. I'm very good at feeling gratitude, and I need the routine of transforming it into expressing it. And so, in particular, right now, I just wanted to express my gratitude for the years that the community engagement team and the government relations team have been supporting the HVAC. And as somebody who has been responsible for staffing the HVAC subcommittee, I have appreciated their support to many kind and gifted individuals on those teams. So thank you. So my opening question, kind of keeping along the lines of that theme, is what is one routine or ritual that you practice that brings you joy? A routine or ritual you practice that brings you joy. And I think we're going to break out into groups. Am I right? Or are we doing this all as one?
I can do that. Give me just a second. I just don't think I can. All right. You should see them open in just a second. Thanks for putting that into the chat, Nina.
Mm. Mm.
And I've had some people who stepped away for a minute.
Mhm.
Nellie, how long are these breakout rooms going?
Um, let's see. Let's give them 8 minutes.
Okay, I'm gonna pause the recording.
Sounds good.
And then I'll try.
We just talked about also remembering the little moments throughout the day that you can just enjoy and be thankful for, as well as they end up helping ground you so you can take on the bigger problems. And so we talked a little bit about that. And there's lots to be grateful for and think about. It's just sometimes you get so busy, you don't notice them. And then we just also shared that my other participants in my room are really cool and do some amazing things. And one day maybe I'll have a garden and can and pickle and all that, but the odds are very against it. But that was amazing to hear about as well.
Thanks for sharing that, Allison. Anybody else want to share? Thank you so much for that, Nina. Appreciate it. Next slide, please. So just wanted to add a new slide to our conversation. Just again, I think we have so much time between some of our meetings. But sometimes I know I get here and I'm like, what did we talk about last time? Or as I'm preparing, I'm like, oh yeah, that is what we talked about last time. And so just wanted to add a slide that helps kind of give us an idea of where we've been as we're kind of preparing for our time together. So just wanted to spend a couple of minutes on this slide, just kind of remembering the things that we've done. This came up at our planning committee as a suggestion from one of the members there, and we thought it was a great idea just to help people get oriented to today, as well as we're looking at kind of the survey response questions. It gives you an idea of what the topic was the time before. So I'll just give a moment here or two for you to read the slide. And if there are any questions that you have about it, please feel free to either put them in the chat or unmute and ask. So we'll just spend a couple minutes here before we move on to kind of the next slide. Yeah, there are. I'm going to hand this back over. Thank you.
Okay, so I am going to talk us through our survey results from our last meeting. We had 6 HVAC members respond, 1 trio member, and we only had 1 subcommittee member, and I didn't have any public opportunities. So for the question of what did you like about this HVAC meeting, I'm going to let you go ahead and read the responses. Take a few minutes to talk about anything. I know one of my takeaways from these is it seems like we had some good pacing with having room to ask questions and have conversations and um, especially around some of these tough topics like budgets. Thoughts by anybody on these? All right, we'll move to the next slide, please. And then there's more feedback. So, thank you for that feedback and it sounds like some of the things that we have in place that Nellie's had in place early on, the going over the roles and values and goals is helpful. So that's great feedback also. Any thoughts anybody wants to share? Any questions? All right. Move to the next slide, please. And what did you find challenging? Go ahead and take some time to read through these. So, something that comes to my mind is that, just that I think with budget conversations, I was thinking in my head, it's like you want it, you want the information, but oh, it's hard to hear, and I agree with this person who said it's tiring. It is tough, so it's a bittersweet conversation. I think always, such an important one. Nellie, not to put you on the spot, but I'm just looking at this third one, and there's some questions in there. Is there anything we want to address now, or just table that for?
I can share a little bit now, and I think there'll be some of it that's covered when we do some of our updates. I think we've shared a little bit around some of the challenges that have existed around the account balance for an extent. I don't know how many years, but for a while we didn't have authority to spend. So we would have the money, but no ability to actually spend it. So we can only spend up until what the legislature allows us to do, regardless of how much money we might have. So there was I think some misunderstanding on what our authority was and what our authority wasn't. And I think we've resolved that issue now. So I know that was one of the barriers there, one of the significant barriers there. I think the other piece, which we've continued to kind of do internally, is a way that the account is set up is unique to I think there's maybe one other account that's set up, it's structured in the same way. So that has also kind of caused us to continue to do some education on the account and how it's structured itself, both internally, kind of within DCYF. So we've had some barriers to kind of utilization. And although we may have had kind of, here's some plans and some ideas on how we can continue to spend this money, it hasn't always kind of worked out, or we haven't had the ability to do that. So we continue to address that, and we'll talk a little bit about kind of what's happened with the fund. Because as I think you know, and we shared, we had a plan to spend down the money that was there, but unfortunately, we weren't allowed to do that. So, and we'll talk a little bit more about that here in a minute. But hopefully, that just gives a really kind of high overview. And if any additional clarification or questions are there, please feel free to ask them in the chat or verbally out loud. And you didn't put me on the spot, Gretchen.
If anything for anybody else? Okay. And then what did you find challenging? Just a little bit more. All right. Before we move on, again, anybody have anything, any thoughts when you read these? I think a lot of it to me is a lot of the hardship that we're all feeling around funding and the budgets, and it's just a hard time. It spills over.
I really appreciate people's thoughtfulness in their responses and being really specific and honest. So I'm just really appreciative of the feedback, and it will help us as we move forward.
Thank you. Yeah, it takes time, and I know, often when we're on a longer meeting, it's like when it's you got to move on to the next thing. That's your email's been blowing up for hours and text messages for hours. So taking the time to give this thoughtful feedback, it really is meaningful, and it's something that matters and that we are paying attention to. So thank you. Next slide, please. What would you like to see changed? Thoughts on these for anybody? I think we were just recently talking about the recommendation work that was happening before. So I know that was something we discussed, and I'm sorry, it's been a long, hard week. Now I'm not remembering where it landed, but I know it was discussed. So if anyone has anything else they want to add to that, great.
I know one of the ideas that was brought up during our last meeting was kind of the thought of, do we continue with subcommittees, or do we do kind of small groups that have like topic areas and maybe kind of a shorter time frame and a shorter kind of commitment around something specific? So trying to think of something that's not coming to mind right now, but more kind of short term as opposed to kind of what we've had, which is more kind of a longer structure time with the two committees that we have, and then the ad hoc committee that we have. So that was, I think, something that was also floated that may be worth kind of spending some time teasing apart as a committee.
Thanks, Simone. All right, next slide, please. Is there anything else you would like us to know? I will say that I also had a hard time with the conversations around expansion, just, with knowing that we have so many programs that are struggling. So it's, one of those tricky things with funding the budget, and it's got to be allocated in a certain way, but so I can echo that feeling. Anything else for anybody here? Raylan said again, very thoughtful and specific. Appreciate that. Yes. Yes, ma'am. A lot of really thoughtful feedback, on some really rich conversations that we had last meeting. So thank you for that. Before we move on, any other thoughts here? Okay, next slide, please. What topics would you like to focus on in the future HVAC meetings? Looks like, people would like more information on other funding options, fixed term small work groups, continued focus on budget. And we see what we have plans. Living with account policies. Any thoughts around these for anybody? Okay, next slide, please. I think everybody's tired from the rain yesterday. Nellie, are we taking a break here or?
Yeah, we can let's take a 5-minute break just to give people a chance to stretch. We have JP, who I don't see on yet and isn't supposed to be on until I think 55 after. So let's take a 5-minute break and then we'll come back, give you a chance to stretch. I've got some sunshine here. I don't know about you, but I'm gonna go stand outside for a minute or two and just kind of soak it in. And I see JP. So JP, welcome. Sorry, I didn't see you earlier. So we'll just take a quick break and then come back in 5 minutes and transition over to you. Thank you.
Okay, thank you, everybody.
Sounds great, Nellie. Thanks.
All right, welcome back, everybody. Just let us know you're back by dropping an emoji or turning on your camera, whichever one you're more comfortable with, so that we know we've got majority of us back and we can um, keep moving forward. All right, so I am seeing responses from almost everybody. So I will transition this over to JP. Thanks for joining us this morning, JP. We appreciate it.
Good morning, everybody. It's nice to see you. Of course, Nellie, I thought I responded to you, so I apologize for you having to be like, what the heck? Um, you get your update from me today, and not Erica, because Erica is out of town. So I will give you kind of a DCYF focused update and take any questions for, figuring out and responding back, just because I'm not Erica and I don't know all the answers. I'm JP, Jennifer Personius. I'm one of the senior policy advisors for government affairs at DCYF. I have been in this role for about a little less than a year, so I'm kind of new. Session was short this year, but intense. We saw our funding get swept. The balance that was being held, that was taken to cover some of the deficit. As far as home visiting goes, there was not major legislation in that space. Um, and as I say that, I'm like questioning myself, but I don't think there was. What ultimately will happen, I think, going forward is that we are looking to maintain. DCYF is putting in a decision package, just a request for consideration. We're reviewing the possibility of moving it forward to talk about the structure of the account, just to make sure that it is easy enough to manage and prevent future, sweeps of funds that are allocated. So right at this moment, we're kind of in a holding pattern, waiting for our leadership to decide what's going to go forward or not. But I think, other than that, we are in an okay space. There weren't cuts to the budget in this area. So if there's something that I have forgotten to mention, please let me know. If there's questions, please let me know. I'm happy to give my best at answering them. And please tell me, Nellie, if that was what you were looking for.
Yes, JP, that is what we were looking for. Appreciate it.
Okay. Oh, come on, you guys. The break wasn't that amazing. You have questions. I know it.
Hi, JP. This is Marilyn.
Marilyn.
I don't know, this isn't really a question, but just like a comment. I shared this with Yvonne and Nicole when they came and did our site visit, but it was really hard to listen to the DCYF legislative update, the overall, where it started with, more funding for child welfare because of things that have happened, and which I think obviously it's needed, and more funding for a prison for young males 17 to 24. And then you get to the end and money is swept from home visiting, and it was very hard when we know prevention works. But like I feel like we stepped back. Yeah, so short-sighted, and that was just really difficult to start out with, where is there an increase, which is all the areas which home visiting can make a difference. So, and I know you know that. That is just my comment.
I think one of the challenges in the work that DCYF does is that everything is very responsive to the crisis of the moment, and with a lack of staffing, with the critical incidents that we're seeing in the little kids and families with substance abuse problems, with the JR population, I mean, they've been struggling with that for years. And so I think, I want to validate the frustration. Like, how do we effectively explain how important prevention is when the agency is running around putting out fires? And so I think that gives me a good idea about where, my team is putting together an interim legislative strategy for the next session. Some of it will depend on what we are putting forward as an agency, but also with the what is it that we want our legislators to know? How can we educate and inform, about the good work that we're doing in the prevention space? And that's something that, we're really trying to start thinking about. So if there are, you know, thoughts about that, I can absolutely help you in that space. And please feel free to email me offline and we can talk about what that would look like. Um, I'm always available for a cup of coffee at a bakery. I'm just saying, happy to get together and chat as long as I get a pastry by myself. I'm not saying you have to buy me a pastry. Let me be clear. Allison, did you have a question?
I did have something to say.
Okay.
So I think, to kind of piggyback on what Marilyn just said, is that when there's no real view into programs and what's happening and why there might be excess funds,
Hmm.
that they can take. So, like, if you had a staff member leave, then you have funds available because, especially if you're rate based, right?
Hmm.
Because, and then it's just like this big circle you can't get out of. So if you don't have
Right.
full staff and you're not bringing in your money, and then everything just kind of snowballs in with that.
Hmm.
And so I think sometimes it looks like one picture, but reality for the next year
Right.
is not that. And so
Right.
it's like you're always basing it, somebody on one of the comments, you're always basing it on old information, not the current situation.
Hmm.
So
Right.
that can be very frustrating. And so that's when you were talking, Marilyn, that's one thing that popped into my mind is that I I get that they have fires, but they're comparing our old information to what we're really doing, and those could be vastly different situations.
Hmm. I think that's a great point, and I would love to um, talk more about how our program team can support you in messaging those kind of things, to from you to us to contribute to the conversation when those things come up. Um, because the more information we have, the better able we are to inform and educate when those things come up. So. Um, and I see that there's a question in the chat about any more about the request for account restructuring. Right now, it's just a very, a general request. I have not looked at the legislative rewrite. It hasn't been rewritten yet, so it's just a request for folks to consider maybe looking at the structure so that there's appropriate spending authority and appropriate, funding streams are clear, and how do we separate it so that, that it's easier for budget to manage and communicate about with OFM. And, so it's right now it's just the request to consider doing that. So there really isn't a, a specific piece right there. So if there was, we would absolutely be getting input. Nothing will happen without you. I love questions and comments, but okay. I will take these comments back to my team and share with them and let them know how some of some of the things that you're looking for us, some of the messaging and education. So I will I will definitely do that, and we'll keep Nellie and Emily in the loop about that. And I'll put my email in the chat, and I'm happy to talk more anytime if you have questions or comments. I don't know if it's as good as Erica, but that's what I got. All right. Well, oops. Let me put my email in the chat, and then I'll hop off and let you resume your regular meeting. Thanks
Thanks,
for letting me
JP.
interrupt. Have a great day, everybody.
Thanks, you too. So we are a little bit ahead of schedule, but I do believe our two presenters from Department of Health are here. And we could transition to that part of the agenda if you are ready.
I'm ready. Debs, are you?
Hi, yeah, I'm ready. Also, I'd be happy to run my own slides if that's easier. I think you have a PDF version, which can be a little hard to work with. One second, let me just get this all into the right mode and stuff here.
Well, I will just do a quick welcome and thank you. I am honored to get to introduce Debs Gardner and Annie McHugh. They are the authors of the 2025 Washington State Maternal Mortality Report. I got to be with Debs in our breakout group, which was really fun to get to know her a little bit. But we're really grateful that you were both able to take the time to be with us today. And this is just a really important report to our work. So thank you very much. And we're looking forward to what you can share with us today.
Yeah, thank you so much for having us. I'll introduce myself and then I'll let Annie introduce herself, and then we'll go into the presentation. So I'm Debs Gardner. I'm the Maternal Mortality Review Coordinator at the Washington State Department of Health. I've been in the role since late November 2021. Really honored to work with the panel and my colleagues here at DOH, and I am presenting from home on Suquamish land in North Kitsap County. And I think that's everything I wanted to share. Annie, I'll turn over to you.
Thanks, Debs. My name's Annie McHugh. I'm the maternal mortality epidemiologist, so I support the report writing and collection. And I've been with the team for about 2 years and had worked in other areas at DOH, sexual and reproductive health, breast and colorectal cancer is some of the other programs I've spent time with. But I'm coming from the land of the Coast Salish people in Seattle.
Thank you. And I will add that we are two of the authors on the report, and there's a whole team of people who supported the creation of this, including many of the members of the MMRP who gave feedback on and generated recommendations for the report. So I want to center us in this vision and message that grounds our work, that any maternal death is unacceptable, and that ultimately our goal is to help to prevent deaths, to address the inequities that drive them, and just work to improve well-being of adults and children all across our state. I want to give you a little bit of background about our MMRP. I know that we've got actually current and maybe even former members of the MMRP on the call today. Some folks are extremely familiar with it, but there may be people to whom this is new. So Washington's Maternal Mortality Review Panel is, it's one of many around the country. This is a map from CDC showing, most of them are called committees, maternal mortality review committees around the country that are that work with CDC and are often funded by CDC to do this work. The dark blue states and territories are funded by CDC. The lighter,
Thanks. I don't think you're
are the
sure.
slides not
I was like, the map in our
Imagine
mind.
Okay, hang on here. Let me try that again. I hit the button and it did not work. One sec. Thank you. Okay. Oh, okay, come back here. Nope, that's not the one I clicked on. Sorry. Okay, there we go. Is that showing up now? Wonderful. Okay, thank you. So I will just walk through those first slides that I was showing. And here is the map showing that most states and territories not only have maternal mortality review committees that are funded through, but they're also funded through CDC. The lighter blue ones are currently doing maternal mortality review and sharing information back and forth with CDC, participating in that work, even if they're not receiving funding. And then the only gray state, Texas, I learned recently, is actually still doing maternal mortality review, but is not working in partnership with CDC or sharing information. But this type of work has really spread around the country, and we all really learn from each other, which is one of the best assets. We share things that work well in Washington, and we learn what works well in other states. In Washington, did my thing stop sharing the external monitor that it's sharing from dark? Okay, I'm so sorry. Okay, is it come back or do I need to reshare?
Yeah, we can see it. We can see it, no problem.
Okay, great. Cable, stay still there. So Washington's maternal mortality review panel was established by the legislature in 2016 following enactment of a Senate bill. And then in 2019, the law was amended to make the panel permanent and add some more details to it. And the law basically directs the MMRP to review deaths of Washington residents that happen during pregnancy or up to 1 year after the end of pregnancy. And the law does some other things as well, like it gives DOH the right to request the kinds of medical and other records that we process to help the panel do these reviews in the first place. So the panel is hosted at DOH. We are the largest panel or committee of this type in the country. Last term, we've got 3-year terms. The term that this report came from, we had about 80 members, and now we've got actually about 100. Not everybody comes to every review meeting, so it's a more manageable number. But we have an incredible breadth of expertise and backgrounds represented on the panel, including a priority focus on American Indian and Alaska Native communities, very reflective of and connected to an inequity-driven disparity that Annie will be talking more about when we go through some data slides. Again, the panel reviews a de-identified summary of each death of a Washington resident in pregnancy through 1 year postpartum. And then about every 3 years, we deliver a report to the legislature and other audiences. I mentioned that breadth and wealth of expertise on the panel. This is not even a complete portrayal in this word cloud. We're overwhelmingly lucky in Washington to have all of the expertise that we have. Pretty much every member brings more than one type of expertise, ranging from lived experience to maternal fetal medicine, indigenous lactation counseling, substance use disorder, perinatal quality improvement, EMS, home visiting, autopsy, emergency care, and just an enormous number of other things. So our review process overall, from kind of a structural level. So DOH starts out identifying and confirming these deaths that took place in pregnancy through 1 year postpartum. And then DOH requests all of the medical and other records that I mentioned that the law enables us to request. And our nurse abstractors, Jill Smith, who was on this committee and just retired, as was mentioned at the beginning of the meeting, she was one of a pair of amazing abstractors who distill what can be thousands of pages of medical and other records into this de-identified summary of somebody's care and death and experiences for the panel to review. And so the MMRP, the panel, meets to review each death and make recommendations for prevention of pregnancy-related preventable deaths. The MMRP and DOH every 3 years work to consolidate and narrow down all those recommendations from all of those reviews into the recommendations of this report and compile all of the data from those years as well. And so the report consists of the findings, the data, and recommendations, among some other details about maternal mortality. We're going to be using a couple of terms that I want to clarify, and these terms come from CDC and help really guide our entire process of review. So when we say pregnancy-associated deaths, that is this big umbrella term that means any death from any cause that happened to take place during pregnancy or up to 1 year later, regardless of whether the death was related to pregnancy. And so a subset of those pregnancy-associated deaths, some of those pregnancy-associated deaths the panel finds are pregnancy-related. They were caused or worsened by pregnancy. And this can be, things that seem fairly obvious and straightforward, like a pregnancy complication or a chain of events initiated by pregnancy. But it can actually even also encompass an unrelated condition that was aggravated by some aspect of pregnancy. And then some pregnancy-associated deaths are not pregnancy-related. The cause had no connection to pregnancy. And for some deaths, the panel determines they don't actually have enough information to determine whether the death was related to pregnancy. So how the MMRP reviews the cases once they get all of that information. First of all, I want to emphasize that this is done very respectfully. We take time at every meeting to honor the people whose deaths that we're reviewing and the loved ones and communities left behind and impacted often inequitably by maternal mortality. And they review this de-identified case narrative summary using the definitions I just talked about to determine whether the death was pregnancy related and whether the death was preventable. And in Washington, we don't just ask whether the death was preventable from a clinical perspective through, intervention, like closer to the time of death, but also was the death preventable from an equity and or social determinants of health perspective, including some aspects of upstream prevention. We ask questions like whether racism, discrimination, and bias played a role. And we ask what factors contributed to pregnancy-related preventable deaths. And then the panel makes recommendations. So what kinds of interventions or systems changes might help prevent a death like that, either at the time or even years before, again, upstream. And those recommendations become distilled into the legislative report recommendations every 3 years that we'll be going into in a little more detail. So this report, if Annie, if you don't mind putting the link for it in the chat, there's also a QR code for it on the screen here. This was just submitted to the legislature in December. It is the 4th MMRP report in Washington. And the aims of it are preventing maternal deaths, raising awareness about the factors that contribute to those deaths, promoting change, increasing health equity, and improving perinatal care overall. The new data in this report are from 2021 and 2022. And there's also some cumulative findings from 2014 through 2022. Annie will go into that in more detail. Some factors like demographics, it makes more sense to look at those cumulative years. Those of you who are very familiar with our reports, first of all, thank you for being very familiar with our reports. But you may notice that the last report, which came out in February 2023, slightly delayed related to COVID, covered 4 New Years, and this report covers 2 New Years. This report basically gets us back on an original schedule. Typically, our reports cover 3 years, and the last one was extended a little bit so they could get a glimpse into the COVID era and include 2020 deaths. And this one kind of puts us back on schedule. So 2021 and 2022, because it takes a while to distill and review all of the information, this is the most recent information that we have. Again, if you're very familiar with the reports, some things that are new in this report, it's a little bit shorter and more focused. There is a stronger focus on the legislative audience. We pulled out the legislative recommendations and centered those first, followed by recommendations for other audiences. We incorporated storytelling. So throughout the report, you'll see sections marked Voices from Washington, and those are stories people shared with us about their experiences with pregnancy, birth, and postpartum, both positive experiences and challenges in Washington. And those help give some context to the legislators and other audiences about why these types of recommendations really matter even beyond the kinds of deaths that we're talking about. There's also success stories in the report about implementing recommendations from the prior report. So I'm going to turn it over to Annie now to go into more detail about the data and findings from the report.
Thanks so much, Debs. You can go ahead and go to the next slide. So before we dive in, there are a few important considerations to keep in mind. First, maternal mortality is a relatively rare event. This means we're often working with small numbers, which can make rates unstable, especially when broken down by specific demographic groups. Additionally, Washington state maternal mortality data is not generalizable and should not be interpreted outside of the context of our state. That said, even with these limitations, we can still utilize these data to identify patterns and make meaningful recommendations and interventions. Next slide. The United States has the highest maternal mortality rate among wealthy countries. In the next few slides, I will provide the national and state level rates, although I won't be showing them together because the national definition of pregnancy-related deaths differs from Washington's definition. The key difference is the national rate does not include injury deaths, such as homicide, suicide, and accidental deaths, which would include accidental overdose. Next slide. So here we have the national rates of pregnancy-related mortality from the Pregnancy Mortality Surveillance System, otherwise known as PMSS. We can see a noticeable increase during 2020 through 2022 compared to previous years. Research has linked the rise experienced in 2020 and 2021 primarily to the COVID-19 pandemic. The increase was driven not only by the direct impact of the virus, but also by COVID-19 exacerbating existing health conditions and disrupting access to health care. Although it's not shown on this slide, the national maternal mortality data also highlight disparities by race, ethnicity, and age. Next slide.
Can I just ask on that slide? The last one, that was probably for the whole country, right? I know that you specifically mentioned us.
Yes.
Yeah, okay. So is it pretty percentage wise with the whole United States the same, or was it more or less?
Sorry, our rate or this rate here? So yeah, this represents the United States, the national rate.
Oh, okay.
Yeah.
I thought this was just Washington State's.
No problem. We're about to dive into that. So here we have the Washington state rates from 2014 through 2022. As we defined earlier in the presentation, pregnancy-associated deaths is that broad overarching category that includes any death occurring during pregnancy or within 1 year after pregnancy. So that's represented by the dark blue line. And that is cumulative and includes both the pregnancy-related rate, which is the light green dashed line, and the pregnancy-associated but not related rate, which is the light blue dashed line. So Washington's pregnancy-related maternal mortality peaked in 2021 at 33.4 per 100,000 live births, followed by 27.6 in 2022. These are the highest rates observed in the 2014 to 2022 period. This increase is likely due to several factors. First, a rise in overdose deaths, particularly involving fentanyl, which has become more prevalent and deadly. Second, deaths related to COVID-19. And finally, the Maternal Mortality Review Panel has continued to evolve their process for deciding on pregnancy relatedness, which can impact the number of pregnancy-related deaths identified. Next slide. So here we'll take a closer look at the maternal deaths in Washington in 2021 and 2022, which is what we covered in the last report. For those years, we identified 107 pregnancy-associated deaths. And then in the second row, starting from the right, you can see that 46 of the 107 deaths were determined to not be pregnancy-related. For 10 cases, it could not be determined whether the death was related to pregnancy, and that left 51 deaths that the Maternal Mortality Review Panel determined to be pregnancy-related. The panel also assesses whether each pregnancy-related death was preventable. Of those 51 pregnancy-related deaths in 2021 and 2022, 42 were considered to be preventable. Next slide. So as we just saw on the last slide, the panel found that 82% of pregnancy-related deaths were preventable, meaning there was at least some chance of the death being averted if a clinical, equity, or social determinants factor that contributed to the death had been different. 82% is very high. However, this means we understand preventability and can take action. Next slide. Inequities and disparities persist in pregnancy-related deaths in Washington. In the next slides, I'll provide cumulative findings from 2014 to 2022 and discuss, depending on age, race, and ethnicity, geography, and insurance status, the rate of maternal mortality differing. Next slide. So the graph on this slide and the following demographic breakdowns will provide the frequency of pregnancy-related deaths in dark blue, which tells us about the actual burden or number of pregnancy-related deaths, and the rates in light blue, which puts the frequency relative to the size of the population or subgroup, allowing for comparisons between groups of different sizes. The rates include confidence intervals, which is important because the confidence interval quantifies the uncertainty around these estimates. And additionally, if a subgroup is marked with an asterisk, it means that the rate has a relative standard error that is greater than 25% of the rate itself, which indicates the estimate is statistically unstable and should be interpreted with caution. So for this breakdown of age, pregnancy-related mortality occurred most frequently among individuals aged 30 to 34, followed by those aged 35 to 39. Although individuals aged 40 and older had the fewest pregnancy-related deaths in terms of absolute numbers, they experienced the highest mortality rate, which reflects while fewer people in this age group give birth and fewer die overall, their risk of dying from pregnancy-related causes is disproportionately high. Next slide. Non-Hispanic American Indian Alaska Native people experienced higher maternal mortality rates than any other racial or ethnic group. Although the absolute number of pregnancy-related deaths is low, their risk of dying from pregnancy-related causes is 7.3 times higher than that of non-Hispanic white people, which reflects an alarming disparity and is why we have an addendum to the report from the American Indian Health Commission, which can be found in the link that Martha shared in the chat. Additionally, non-Hispanic Native Hawaiian Pacific Islanders, non-Hispanic Black, and non-Hispanic multiracial individuals experienced high rates of pregnancy-related mortality. Next slide. When we look at pregnancy-related mortality by an individual's primary insurance, people with Medicaid experience both the highest number of pregnancy-related deaths and the highest mortality rate at 36 per 100,000 live births. These figures highlight the critical importance of ensuring access to quality care throughout the perinatal period for individuals covered by Medicaid, especially since Medicaid enrollment often serves as a proxy for social determinants of health, such as income level, housing stability, and access to other basic needs. Next slide. Lastly, we'll look at pregnancy-related mortality by rural-urban residents. Although 122 pregnancy-related deaths occurred among people living in urban areas, the overall mortality rate was highest among people in rural areas at 26 per 100,000 live births. This underscores the importance of improving access to quality maternal health services in rural communities. Next slide. So now that we've looked at how pregnancy-related mortality varies across different demographic groups, I'm going to shift our focus to better understand why these deaths occurred. Next, we're going to explore causes, timing, and contributing factors behind these pregnancy-related deaths. This will help us see the bigger picture of the challenges faced and where interventions might make the greatest impact. Next slide. So looking at the pregnancy-related deaths from 2021 and 2022, the top 5 leading causes of pregnancy-related deaths were accidental overdose, COVID-19, suicide, and cardiovascular conditions, including peripartum cardiomyopathy, and also thrombotic embolism. These causes highlight a mix of clinical, mental health, and social challenges that contribute to pregnancy-related mortality, underscoring the need for comprehensive approaches to prevention and care. Next slide. Most pregnancy-related deaths occurred within 43 days to 1 year postpartum, followed by deaths within 42 days of pregnancy. These findings underscore the importance of care support and health insurance coverage through 1 year postpartum. Next slide. The panel identified contributing factors that led to each preventable pregnancy-related deaths. These factors are defined by the CDC and are the events or circumstances that, if different, the panel believes might have prevented the pregnancy-related death. The graph on the left represents the top 12 contributing factors. I'm going to highlight the top 3, which were lack of continuity of care and or care coordination, lack of access to care or financial resources, and clinical skill or quality of care. For each identified factor, the panel made recommendations to prevent future deaths. Those recommendations are going to be discussed in the next part of the presentation. Next slide. Before we move on to recommendations, it's important to highlight that the panel found discrimination, bias, interpersonal racism, or structural racism played a role in 76% of preventable pregnancy-related deaths from 2021 to 2022. This really emphasizes the need to center Black, Indigenous, and other communities of color as leaders in the successful implementation of many of the recommendations shared in this presentation and in the full report. And with that, I'll hand it back over to Debs to go over recommendations.
Thank you so much, Annie. And as we talk through the report recommendations, I think you'll understand from that data presentation the context of why the recommendations we see were prioritized. So the report recommendations are organized under 3 kind of umbrella priority recommendations. And under those 3 priorities, which we'll talk about in a moment, there are 12 recommendations for the legislature and 75 for other audiences. I put the page numbers up here, as well as some examples of the audiences, just because it's easy when you're looking at the report to only see one section or the other and think maybe all the recommendations are for the legislature, whereas there's actually many recommendations for other audiences too. Also, we focused that number of legislative recommendations down to 12 of them, but the legislative recommendations in particular are highly detailed with a lot of examples under them. When I show recommendations in a couple moments from each of these categories, the legislative ones I will have shortened generally to a sentence or 2, but usually you can look under it in the report and see many examples. So let's delve into those 3 priority recommendations. Here they are succinctly. So there's one about improving healthcare quality and access, one about strengthening community support services, and one about providing equitable, culturally responsive care. So let's go into these in some more detail. So the first priority recommendation, to improve healthcare quality and access. And specifically, this is a recommendation to ensure that Washingtonians have access.
Oh, yes? Sorry to interrupt. It sounds like you're having some feedback on your microphone. Do you want to try muting and?
Yeah, let me mute and unmute, and let me also try plugging in. Okay, so. How is that? Great. Okay. Thank you for letting me know. Thank you for the feedback. Pardon the pun. Anyway, so this recommendation is specifically to ensure that Washingtonians have access to, excuse me. Can you hear me okay? Okay, great. Thank you. Ensure Washingtonians have access to high quality care, including mental health care, substance use disorder treatment, and preventive care, and that this care should be birth and postpartum, and to do this by things like strengthening and funding care coordination, improving communication and protocols, and ensuring providers have the skills and the training and the professional support they need to provide high quality care. So let's look at some examples of recommendations under this category. I won't be showing you every recommendation in the report. As you saw in the numbers, there's over 80 of them, but I have pulled out in each of these 3 sections a handful that I thought might be of interest to this audience. So under this first category, there's one for the legislature to protect and increase funding and access for family-friendly, judgment-free substance use disorder and opioid use disorder treatment and support for pregnant and postpartum patients across Washington, including in rural areas with limited access to community services. Again, lots more detail in the report version. There's also a recommendation that DCYF should help healthcare systems and providers strengthen support for pregnant and postpartum people experiencing substance use disorder who may not otherwise seek care if they fear intervention from Child Protective Services. There's a recommendation for agencies, healthcare systems, facilities, and providers to increase access to low barrier, comprehensive sexual and reproductive health care along the entire reproductive health continuum in a range of settings, including substance use disorder and opioid use disorder treatment facilities, local health departments, pharmacies, mobile units, community clinics, and home visits. The second priority recommendation area about strengthening community support services, and this is specifically investing in and developing and expanding comprehensive community support services that address essential needs during pregnancy and postpartum. These include strengthened home visiting programs, as well as social work services, doula support, and wraparound support for mental health and substance use disorder. So some examples from this section. There's a legislative one to expand support for universal access to wraparound services through pregnancy and at least 1 year postpartum, including home visiting, doula support, and peer support workers. And again, with this one and the next one, there's lots more details in the report. Another one for the legislature to prioritize both protecting existing and funding new programs that meet people's basic needs in pregnancy and postpartum. Ideally, access to transportation, housing, income, and childcare would be universally available. Specific recommendations include, and I pulled one of the examples from under this, support access to high quality universal childcare services and early childhood education, prioritizing ensuring childcare access for all families during both routine and crisis situations, as well as during medical visits to make sure childcare is not a barrier to healthcare access. I know some of the folks on this committee work specifically on access to childcare issues. There's another recommendation for DCYF to expand partnerships and provide funding for local social support systems that offer trauma-informed care and support for children and young adults who are or have been part of foster care systems or experienced involvement with CPS. So here's a couple of recommendations that specifically mention this committee. So I've highlighted that here. So there's one for DCYF to collaborate with DOH to inform the Home Visiting Advisory Committee and seek its advisement on strategies to prioritize high quality prenatal and postpartum home visiting, as well as other home-based services for people experiencing mental health conditions, substance use disorder, or opioid use disorder, or other high-risk circumstances, and that home visitors should receive specialized training to effectively support families affected by mental health and substance use challenges. There's another recommendation for DCYF to work in coordination with DOH to explore opportunities for expanding access to home-based services that support chronic disease and medication management, particularly for conditions such as hypertension, diabetes, and opioid use disorder. And as part of this effort, DCYF and DOH should inform the Home Visiting Advisory Committee and seek its advisement on how best to align future funding opportunities, model selection, and service delivery approaches. This work should consider the scope and limitations of existing evidence-based home visiting models. So again, those are numbers 2.7 and 2.8 if you want to kind of spend some more time looking at those in the report. A couple more examples from this second section. There's a recommendation for the Healthcare Authority to strengthen access to first steps or maternity support services and ensure that services and tools are comprehensive, high quality, culturally relevant, and trauma informed. And the program should be adapted to better meet the needs of people during pregnancy and postpartum, especially those experiencing mental health conditions, substance use disorder, opioid use disorder, or intimate partner violence. There's a recommendation for DOH and other agencies to raise awareness about resources people may be eligible to receive in pregnancy and postpartum. Awareness efforts focusing on services of like MSS after pregnancy coverage and short-term childcare that provide temporary respite to parents. There's one for DOH and local health departments to invest in building healthy and safe communities, including working towards systems level changes that address social, relational, and service gaps and support communities in developing more robust early learning, education, childcare, parent support, healthcare, and economic opportunities. There's one for educational service districts, school districts, and other educational institutions to integrate upstream strategies into education to improve mental health, prevent violence, and promote healthy relationships. So finally, our third priority recommendation area on providing equitable, culturally responsive care. And this is specifically to ensure care and services throughout pregnancy, birth, and postpartum are culturally responsive, free from bias, and grounded in trauma-informed practices and actively address racial injustice. So some examples from this section. Again, a couple legislative ones. One that the legislature should support culturally aligned care for pregnant and postpartum people. One of the many examples under this is including funding for culturally adapted home visitation, peer support, and care navigation programs embedded in communities experiencing the greatest disparities in maternal outcomes. There's another one that the legislature should support pregnant and postpartum people experiencing intimate partner violence by providing low barrier access to services and making systems changes to increase safety. And there's one for healthcare systems providers and state agencies to ensure that tribal and urban Indian health leaders and communities guide the provision of culturally responsive care for American Indian and Alaska Native communities. This means providing access to culturally responsive care through patient navigators, tribal liaisons, community health workers, doulas, and social support networks. It also means integrating tribal-led and other indigenous-led nutrition planning and health practices into perinatal care. A couple more examples from this section are that DOH and healthcare systems should fund tribal-led, indigenous-led, and community-led efforts to expand access to prenatal and birthing care in American Indian and Alaska Native communities, including in rural areas. One for healthcare facilities and providers, including primary care and support providers, to routinely screen for trauma history and tailor care to respond to the impact of trauma on mental health and well-being. And this might include things like screening pregnant patients for both adverse and positive childhood experiences, ACEs and PCEs, and offering enhanced wraparound care. And one for all clinical providers, including those working in emergency departments, to be trained to recognize stigma and bias and to provide trauma-informed care, including understanding historical and systemic factors that contribute to disparities in biased care provision, particularly in areas of pain management for BIPOC patients. A couple more examples from this section before we move on. Because these are very important, as are they all. There's one for healthcare systems and providers to offer compassionate, respectful care for people with substance use disorder or opioid use disorder. And this means supporting stable, nurturing parenting rather than relying on punitive measures and ensuring treatment options and referrals are based on need and not influenced by bias. There's one for DCYF and partners to provide proactive community-based resources to help families safely stay together and strengthen relationships between children and their fathers or other non-birth parents. This includes offering culturally relevant parenting support and addressing barriers such as incarceration, poverty, or CPS involvement, as well as expanding access to early voluntary services to support families in pregnancy and postpartum. And finally, one for the Department of Health to support systems change to prevent and address intimate partner violence, domestic violence, and gender-based violence by requiring trauma-informed care training and certification for providers and facilities. This includes funding community programs that offer education, advocacy, counseling, and training for health systems to support people experiencing violence. Okay, so I want to recognize some of the current context and emerging challenges, including emerging challenges we may not yet know about. We just want to recognize that both at the state and federal and global level, there's a lot of challenges and issues that can make the recommendations in this report simultaneously more challenging to implement and also even more important. And so just calling out a couple of those. So we have concerns about impending Medicaid cuts. Medicaid covers 45% of births in Washington, and that's 70% of births in rural areas. And that's one of the many ways that shows how some of the inequities and disparities we looked at are deeply intersectional. And tying that again together with rural maternity care shortages. There's perinatal and reproductive care access challenges and fears around the country that can also impact into Washington in various ways. There's challenges with access to mental health care. We know there's a lot of funding issues out there right now, state and local budget limitations, and just the current funding landscape in general. There's misinformation and disinformation around vaccines and other issues. There's threats to immigrant, BIPOC, and LGBTQ communities, and also people who may be perceived as parts of those communities. And there's just a lot of uncertainty about health, environment, and society in the future. I always think of this one because even before I started, when the MMRP report came out in late 2019, the COVID pandemic started just a couple months after that. There was no way to see that coming. And we don't know whether there are future pandemics or what other changes might be around the corner. But with all of this in mind, this is why the report includes recommendations that both protect what we already have, protect existing services and resources, and also take new steps because those are necessary to make progress on preventing maternal mortality. It's also why some of the recommendations require legislative support or funding and some don't. So implementing recommendations from this report, I look at this as kind of both centralized and decentralized. There isn't one entity that's in charge of implementing all of these recommendations, but there are some that are a little more centralized. So like the legislature does something, legislative change based on one of the recommendations or other statewide efforts, some work led by DOH or the Washington State Perinatal Collaborative. But the Perinatal Collaborative also highlights efforts that are happening in a more decentralized manner. And this is basically any work around the state towards any of these recommendations at any level whatsoever. And that can be local and regional efforts. It can be led by any organization, entity, coalition, or individual. It can be practice level or regional level, like literally somebody making a change to their doula practice or medical practice or home visiting structure, anything like that. That's implementing recommendations from this report. And also just recognizing the work of regional perinatal collaboratives and committees such as this one and all that you do to create change that's aligned with recommendations in this report and our past recommendations. So speaking of connecting your work to recommendations, this is where I just want to invite you to think about what recommendations are most relevant, whether it's to this committee or in your own work or in your own community or communities. How can the report's findings and recommendations support your work and priorities? Is there something that you're already working on or interested in getting started in working on that's aligned with any of these? And if so, who do you want to collaborate with or what entities do you want to collaborate with? Is there something that you want to get involved with? And are there other efforts that you want to highlight? So basically, how does this connect to your work and what you hope to do? And how can collaboration help that? We're also happy to take any questions, but just want to invite conversation on this. Laura, go ahead.
I just wondered if we could put the recommendations related to the Home Visiting Advisory Committee in the chat, so we could see those alongside this question as well. Is that possible?
I can work on that. Just hang on a moment. Yeah. Christy, and I'll work on getting that done. Christy, go ahead.
One thing that I noticed, I heard it because it's what we're doing. We have collaborated with our in-house care coordination capacity with those who are on our parents as teachers caseloads. So for many of the families, they're receiving wraparound services at the same time.
Nice.
So I was kind of excited to see that that's actually in some writing because we're just grassroots doing it.
That's lovely. There's a lot of love for that happening in the reactions. Thank you for sharing that. Here, hang on. I think I have to share these two one at a time due to length. And, okay, there we go. I think I have both of those shared on the chat now. What else do folks want to share, ask us about, ask each other about?
Sorry, I didn't raise my hand. This is Laura again. I'm curious about the group's thoughts, particularly around recommendation 2.0. I'm curious about both of them, but yeah, I'd love to hear what people think of these recommendations as they relate to the Home Visiting Advisory Committee and the second one especially.
Marilyn, for lack of other people calling, I'll call on you.
Thank you. My comment isn't specific to what Laura just asked, so I apologize for that. So a couple of things we're doing in Yakima County, and I just want to say this, there's so much in this report, so much great data and things for us to work on. So I just really appreciate it. So our Nurse Family Partnership program has a partnership with Tatawak Birth Justice Center, which is on the Yakima Reservation. And we have 2 NFP nurses that work jointly with them in providing services to families. And so, and they direct all the work that we do. And one of the things that that they are working on currently is a standalone birthing center. And we've got a ways to go on that, but the data around the rural, the impact of access to care in rural areas. One of the hospitals on the reservation no longer delivers babies. Toppenish Hospital does not. And so women are traveling further. And in Toppenish, OB care at Farm Workers Clinic is also no longer provided. And yeah, so it's, I feel like our work with them is so important and that it is led by them. And one of the things we're also working on is a clinical pathway around pregnant and postpartum women for American Indian, Alaska Native women that we're serving, and really trying to focus in on what are those things we are doing to address specific issues. And I just 100% like with our population too, I think the access to care is so difficult. And then access to mental health resources and support with domestic violence and toxic relationships also. And then the third thing that we're doing, which has taken just a lot of work, but we've stuck with it. And I think we've met 3 times now, but the leaders at Tatawak Birth Justice Center asked if I could support them in meeting with the labor and delivery, mother, baby, women's services, and emergency department leaders, because that's where women are coming in, families are coming in. And we've been able to meet 3 times to talk about like what is their experience when they come in for care. When there is a problem, how can we address it quickly? And who should we be who else should we be inviting? Also talking about how can their birthing experience be more culturally sensitive and their needs being met. So there was a lot of pushback on that from the hospital I work for, which I'm ashamed to say, but not pushback, but just dragging their feet, just not making it happen. And I'm just really excited that we met monthly. Now we're meeting quarterly, and there's engagement around that. And I want to bring some of these findings to them as well. So thank you for this.
Thank you for sharing all of that. I want to go to Gretchen, who I know is very helpful in a lot of the development of these recommendations in the report. Gretchen, go ahead.
Thank you so much for coming on today and sharing all this. It's so important. I have a lot of thoughts and trying to formulate them all well. I think that this really speaks to the power and the value of home visiting, and it also speaks to me around like the portfolio approach that we have in Washington State, and the importance of that. And then also looking at this and and seeing over the years how the acuity of families has only gone up, and I know in Thurston Mason Lewis where we're living, we're seeing very very high acuity families, and I'm sure that is happening all throughout the state. So one thing that comes to my mind, just I think for us and when visiting, is thinking about how do we support familiars, but then how do we also make sure that families or individuals that might need that like really higher level of care of looking at toxicities, medication management, like that we're as a community making sure that they are maybe they're getting to them to come visit them that with maybe that maybe that's a nurse, right, that needs to be doing that more than somebody else. But also so I think the team approach really is what's standing out for me. The other thing that comes to my mind is our NFP site. We were able to get a licensed social worker 2 years ago after I pushed and pushed and pushed for years with local funds through the 1.1% funds, because we had there's a limit as to how much a home visitor can do, right? They can do a lot, but then we were finding is we had clients that were suicidal or experiencing economic psychosis, and we'd send them to the emergency department. They'd sit there for 6 hours and then they'd send them out. So it just was this constant cycle. And then it's 6 months before they could get into a mental health provider because access to care is so bad. So, sorry, I'm kind of rambling. It's just all standing out. I think my takeaway is just how important it is, there's not any one profession that can address this alone. We've got to work as a team. And then also making sure that we are getting families to the right level of care and not burning out our home visitors if they maybe they have no medical background, and then they're dealing with these really high acuity situations where somebody has complicated medications or complicated histories. It's my thoughts.
Thank you, Gretchen. I think that highlights. I'm getting an echo now. I think that really highlights how intersectional the issues are, and also how intersectional the solutions are. As with any kind of report like this, implementing multiple recommendations at once is really kind of the picture of systems change rather than just one piece or the other, because they all depend on each other. Allison, go ahead.
Hi. So I'm going to pull some of the information from this as I kind of move forward in some of the grant and work that I'm trying to do, because what we consistently see is people that maybe are trying to refrain from using substances, but might be going back and forth. Also, maybe that are super new in their recovery, but they're further along in their pregnancy. There's just a lot of I'm not going to the doctor. And then there's a lot of I finally go to the doctor and they're rude to me, so I'm not going back again. I mean, we've actually witnessed that happening with somebody and said, hey, well, we're here now. So let's what are the next steps in trying to change the conversation and their approach. But I think that is a huge area that needs more support. So when you talk about helping those families specifically, I think it's a hospital doctor kind of situation, but also how do we create within our work with these families the encouragement to go to these appointments, because people can't be jailed for using drugs. So why do we want to continue to create barriers so they don't feel comfortable going in, so we can have at least as healthy of a baby born as possible? It just angers me. So that's a personal thing that I hope is addressed more somehow. And we also have really been thinking, because we had a lot of our youth that are in extended foster care have babies in the last year and a half. And those are kids that, have been in care for some of them, like the majority of their life. And so they didn't have that consistent connection with somebody and the opportunity to kind of learn about parenting. And they're going in and having babies and they have no idea. And they don't have a grandma or a mom that can say, okay, everybody talks about swaddling, but here, let me show you what a swaddling looks like. It's just really basic things for some of these parents that never had that support before. And it's really time consuming, and it's also, it needs to happen more frequently than just typical home visiting. And there's not really the ability to catch that work right now, I feel, in the services we provide. But it's something that I would love to be able to filter out and kind of somehow show the need for it, the outcome of having that service and what that reduces in the long term, whether that's mortality or those children being picked up at a later date. I don't know how to do all of that, but I feel there's something important in that data if there's a way to gather it, because I would suspect that those parents are at a higher rate of suicide, of relapsing into drugs and having their children picked up by DCYF. So yeah, I would love to maybe be connected on who could help filter that information so we could really develop a better approach to serving them.
Thank you. Invite any responses to that. I'm also popping our contact information onto the screen here. Something you were saying, Allison, reminded me. We offer presentations on this to any relevant audience that is interested, and can tailor the presentation to different lengths of time and priority areas and such. So yeah, please do get in touch if that would be helpful. And also regional presentations too. We found that sometimes just conversations in a particular geographic region to spark some conversation about, okay, what do we want to prioritize here? What do we want to do? What's already going on can be useful.
This is Marilyn. I will definitely be contacting you guys about that for Yakima County. I've got a couple of ideas, but I'm just so appreciative of what you shared, Allison. And we find similar things here of that when parents finally go in for care, when women go in for care, then they're treated poorly. And well, why would they want to go back then? And it's just heartbreaking how often that occurs. And so I appreciate you calling that out.
Yeah, agreed. Christy, I see you also have your hand up. And Allison, I think your hand's still up from before, right? Okay, just checking. And Christy, go ahead.
Yeah, we also have that experience of where we help to get a family to a provider, and they, for whatever reason, it's like that is not working and I will not go back. So I completely am resonating with that comment. And I was curious if because we're in Lewis County, so do we, with this information, are we seeing more providers? Are there programs that are being developed so that we get providers to the rural areas? Because our people who are pregnant, like in White Pass, are driving to Centralia for services, or, our local hospital, you don't deliver there anymore up in Morton. And so then they have to come down to Providence, and then they either go to Centralia or they come up to Olympia here. So are there provider encouragements for doing rural service? I'm just so curious.
Thank you. I'll say before I turn over to Gretchen, who can probably speak better about what it currently exists, just to acknowledge that in the report, there's a whole bunch of recommendations about strategies to both preserve and increase access to rural perinatal health care providers and services. So very much on the radar. Gretchen, go ahead.
Just two things. One thing I think about, like some of our rural communities and individuals that are fearful of ICE, how much we have seen them not going in for care, and in some cases, it leading to some really poor outcomes because they were so fearful of going. So that is one thought I just think about, what will that do to the rates maybe the next several years at the same purpose. And then the other thing is stuff, piece of side note, I guess we got to talk to my foremost office every day, asking if we had pregnancy tests, because I think as a result of reading this report, so they wanted to make sure that they have pregnancy tests to make sure they, checking individuals. So, and the other thought that came to my mind is like how tight everybody's budget is if they're having to go outside of their office to ask us about the next. So, and luckily we have some, so we were able to share them and to do that. But I just thought it was meaningful to me. I was like, oh, okay, they took something from this and they're taking action. So good work for you.
Thank you. For the recommendations on increasing care access in rural areas, like I mentioned, there's a lot of them. One of the legislative ones is on page 20 of the report. It's recommendation 1.6. If somebody wants to look at that in more detail, I put the link back to the report in the chat. We have at least also one recommendation in the report about getting access to care regardless of immigration status, to just related to something that you're saying, safely accessing perinatal care, including for immigrant and refugee communities. Nina?
Thank you. And what an important body of work, and I'm so grateful to hear the recommendations of DOH and the HVAC working together. I just wanted to, something that I've been struck by listening throughout this entire morning, but also as being in this place of reflecting and reflecting back on the HVAC recommendations and these beautiful recommendations that you've made here, and how there's this theme through this meeting of the impact of financial and time scarcity on the implementation, on the people doing the implementation of providing these services to families, as well as what families are receiving, and wondering about whether this group can, that I think in the HVAC recommendations, we started to articulate how time was as important to have as money was to have, and yet still the emergent kind of things that come up similar to what JP was talking about in the governance report, impacts and stops or slows progress being made, and how are there ways, I don't know if I'm articulating this well, but are there ways that we can develop our language of describing those needs and embedding them in the work that we do, so that the legislature is seeing that on a regular basis as well. And maybe that's a pie in the sky um, kind of thought, but I found myself thinking about that. And also, Debs, I just have to say though, I wanted to make a pun about frog in your throat when you had the static on your on your own sound, but anyway, so I couldn't pass on that.
I'm a great
Thanks.
appreciator of puns. That is one of my side facts about me. So I appreciate that. The frog has not leapt off of my background, and I actually have many of these frogs on our property here. But going back to your very important points earlier, are there any thoughts on that, and keeping in mind what you were saying about the role of funding and time limitations, and the legislature's focus? Did anybody have anything you wanted to say about that comment? Just want to recognize also with that, while you are thinking, one of the challenges I feel like we sometimes hear in multiple audiences is, because of that scarcity you mentioned, almost like an anxiety of limited resources, of like, well, if we do this, does that mean we can't also do that? And if we prioritize this population, what about that one? And I try to bring us back to that topic of intersectionality, that it really does require addressing this from all angles, and that ideally we shouldn't be choosing between different communities to focus on different priorities, because they all depend on one another, but it is challenging.
Any last minute thoughts, questions for Deb and Anne?
I just put my email in the chat again, so it'll stick around. Yeah, thank you all so much again for this opportunity.
Thank you all so much for making time this morning. It's a great conversation. Do Why don't we take, and we've got a little bit of time, let's take 15 minutes. Let's take a 15-minute break. And we'll connect back.
Okay. Welcome back to everybody. Nellie, are we at time? It's going to remember the exact time. Okay. All right. So I'm going to pass it over to Nellie and team for DCYF updates.
And Nina is actually up first.
Sorry.
Thank
Nina.
you, Nellie. Hi, everyone again. Just wanted to share that next week is the National Home Visiting Week, and Washington State is joining the celebration. And our governor made a recording that we're going to be sharing with the workforce, as well as a proclamation. And I don't have those with me today, but we will have them during that week. And so we're looking forward to that. And I put the webpage here for you if you want to access more information about that or share information about that week relative to the work that you're doing in the communities that you're serving. So, and also just give a plug that this is something that's sponsored by the Institute for Family Support. And they, Janet Horace, our the executive director of the Institute, will be presenting at our upcoming All HVSA meeting to describe more about what the Institute is doing and to how it supports home visiting as a profession. So that's it. Thank you. I forgot to put that slide in there. That's what I was just talking about.
Thanks, Nina. Next slide. I am not sure if Laura is, there you are. All right, Laura, thank you.
Hi, good morning, everyone. Laura Alfani with DCYF Strengthening Families Washington Team Administrator. Just wanted to note that with the legislative budget that was passed in March, there was a one-time removal of funds from the home visiting services account. These are state dollars that had accumulated. Those have been removed, so we're projecting that at the end of the fiscal year, our balance will be near zero. And we'll be working over the coming years to support our fund balance to stay low like this. So just wanted to provide that update. I can't remember if there's another slide, Nellie, on this. If you all could go to the next one. I feel like there may be two. Yeah. Oh, there's a note slide there that didn't get deleted. So just so you all know that I was working on getting that graphic updated and couldn't quite get it. So that should be zero at the end of state fiscal year 26. And we can remove that text before we send out slides, please. In that. But just wanted to note that we have seen a declining balance for the last several years. And then the legislature removed the remaining balance for the beginning of the next fiscal year. I think you can go to the next slide probably, unless there's any questions. Wanted to share back with you what, following the conversation we had in February and the recommendation vote that we had, and kind of just what our next steps have been and where we're at. So just wanted to first note that this is a slide from February. This is what we presented on what our DCRS recommendation was to get some additional dollars out to local home visiting programs. And so that was getting to as close as we could to the 90% of the rate, and then doing an expansion, really a startup of a small parents as teachers program in Spokane County. And I think maybe on the next slide, it shows the voting results and how we approached it. So I'll just start this and then I'm going to pass it off to Nicole. So based on the feedback that we received from you all, we met with option 2. It wasn't, I would say, a consensus, but it was the majority of people that voted for that option. And so, Nicole, I'm going to pass it to you to talk a little bit about what we've done since then and where we're at in the process. And I think there may be one more slide, so maybe 1 or 2. So I'll pass it to you.
Awesome. So yeah, we did keep that value in option 2 on the last slide of a minimum and a maximum with a couple of adjustments. But some of the things that have happened since then, I believe we shared with you that we were waiting for some updated workbooks for NFP and PAT so that we could do a rates informed approach to these increases. And we did get those. So they were updated with more recent salary data, with health insurance and operational costs. And the updated workbooks increased the payment, the rates pay, what would be the rates payments if we were in rates, about 10 to 30%, depending on the region and also depending on which workbook it was, whether it was NFP or PAT. And so then as we saw that adjustment happen and we updated those numbers, the case rate numbers, the new target was closer to 80% of the rate rather than 90% of the rate because we got some more information that said basically it's going to take more money, as we're not surprised. It's going to take more money to implement these new changes with more recent salary data and health insurance and operational costs. So we saw people's percentage of what would be the rate drop, and we tried to get as closely to 80% for every McPhee LIA that was getting an increase. And so those amendments are now at the very beginning process. We have issued emails to the McPhee LIAs that are getting increases within the last week or so, and those came from the program specialists, the PS5s. And we are starting to route those amendments as soon as LIAs are giving us the information on how they would like to spend the increase that they are getting for their McPhee funds. So generally, that's where we're at. And then I think I'm going to go ahead and go to the next slide. And then if there's any questions, feel free to unmute or pop them in the chat. I have my chat open as well. As I shared last time, I believe, just a little update on the Spokane expansion. A limited procurement for 2 home visitors for PAT is in development. We are estimating, and we'll say estimating here because hopefully we'll be able to get it open by June. But that's what our current plan is with the work plan that we have and the outline that we have going here. It will be my first application with home visiting, so that's exciting. I've done some with other programming before, so I'm really excited to see how it goes here and note the differences and things like that. So anyway, we're estimating that we are going to release that hopefully in June. And along that timeline, we would hopefully then have a contract for this new program starting in September-ish. And then just a note here, if you have ideas for communication or outreach or, have any questions or anything, please feel free to send me an email. My email is on the slide there. And then the other thing that we'll probably be doing at some point in the next couple of months too, as we start to build this application process, is we'll be reaching out to this group to see if there's any interest in helping with the scoring process. So more to come on that. And I think that is it for my portion, unless folks have questions.
I'm not seeing any questions in the chat or hearing any questions, so we'll move on and there'll be another opportunity to ask some questions. So just wanted to share with you, so we're gonna tag team, Lee and I are gonna tag team this slide. So we are feverishly working on our McV grant, which is due Monday. So we are close to the wire. We're doing our final reviews, and hopefully we'll be submitting everything in on Friday to then hit the button for it to go to HRSA on Monday. So that's kind of where we are with that. And wanted to just again highlight that we did get a budget increase, and the amount is recorded here, $741,089. And all of that has gone to LIA increases. Now, some of that Laura had shared in kind of a couple of slides, and the Spokane expansion. So we are happy that we've gotten an increase and we have been able to pass that on. There are other McV kind of updates, and I'll pass this on to Malia to talk a little bit about those.
Hello, my name is Malia Lindsay. I'm the Home Visiting Program and Policy Analyst. So as Nellie stated, we're working on the application for McV and some of the other McV changes that are coming up. There's several reports that we report out to McV, and they are one of them is our annual performance report, or as many of you have heard of it called as the APR. And that's where most of these changes are coming in. So starting October 2026, some of the new things that LIAs will be required to do if they are McV funded is an anxiety screening, and that includes a referral. So right now, a depression screen is just required, and so there will be an added anxiety screening, and that includes the referral if it's a positive screen. Also, race and ethnicity. So in previous APRs, it was two separate categories, and it did not have Middle Eastern or North African category. And HRSA has stated that they will be combining race and ethnicity and then also adding Middle Eastern or North African category. Also, for safe sleep, they will be adding a 2-week look back period. So the question will stay as is. I believe it states, no co-sleeping, no bedding, things like that. And then it will say in the past 2 weeks. And so right now we are working with the model offices and the data systems, Visit Tracker and Flow, and PAT and Changeant national offices to figure out what changes they will be making to answer to these changes, and then what things we need to work on for McV funded LIAs. So we do have a work group of DCYF, DOH, and Start Early, and we are trying to figure out the best way to communicate this information to LIAs and to clarify our responsibilities versus the national offices and the data systems. And we will keep everyone updated as we know more. And I think that's it.
I can speak to this quickly, Nellie. I just wanted you all as the Home Visiting Advisory Committee to see where the distribution of the McV grant has been. There is now a kind of a three-part budget that is required for our grant applications. It's fairly complicated. Oh, I'm sorry. And we're applying now for FFY 26. And then you can see now what we're projected for FFY 27 as well. So just some info around the grant budgets. And then Nellie, I don't know if you want to call for questions.
Thanks, Laura. Just wanted to pause here and see if there are any questions, and not necessarily about this slide, but we have put a lot of information out there. So just wanted to pause here briefly just to see if there are any questions.
This is Marilyn. Do we have any concerns about state matching funds based on the state budget?
Good
You
Lord.
want me to go? Yeah. Not at this time. Really interesting thing that this may change when MCV is reauthorized. Hopefully it'll be reauthorized. But when it was reauthorized last time, they actually set the match and maintenance of Everett levels at FFY 29. So it was before we had more expansion that we've had and we've been able to maintain. So at this point, we are not concerned about that. Again, that may change with reauthorization. And if HRSA decides to reset at that time the level of maintenance of effort and match, it may be a different story. But through this period that you see, which was the 5-year authorized time that we're working through, we're not concerned at the moment. And the good thing is, HRSA has, when states have not been able to access their match because maybe they don't have a state match, they're redistributing that, and we've been able to benefit a little bit from that. It's not huge dollars. It may be like $20,000, $40,000, maybe 60, maybe more next year. But we have been able to leverage when other states have not been able to meet their match, they're redistributing that. So that's great. And then the last year, which is authorized year 27, is when we have actually the largest increase. So it's been about $750,000 from 23 to 24 to 25, 26. And then as you can see in 27, it's a much bigger jump, which is pretty interesting as the last year of the authorization and then not knowing where it'll go after that. So we'll have to be working with you all to think about our budget for that.
There aren't any other questions. We'll move on to the last part of our agenda. And so we had planned to have lived experience experts from either our ESIT State Interagency Council. I say that hesitantly because I can never remember what the acronym stands for.
Coordinating Council.
It was close.
State
I was
Interagency
close.
Coordinating Council.
It will stick one of these days. I promise it will. Or from our parent advisory group. And the two individuals that we reached out to were not able to make it today, but are available for our meeting in June. So we'll still have an opportunity to speak directly to them and to hear kind of their experiences and to gather information. And I think it's actually kind of worked out well, because in our kind of our planning meeting and our discussion, one of the things that came up was just kind of defining what we mean by lived experience experts. And I don't think we had spent time, or you had spent time as a committee really kind of thinking about like what do we mean when we say that? And when we say what do we mean, then who naturally falls into those categories once we define. So I think the next slide is going to kind of come in. Next slide. So this is just, again, our member profile. Just wanted us to take a look at it as we kind of engage in this conversation. I also want to note that we lost an HVAC member with Jill retiring. So that's a position that we want to consider of how we fill that. Next slide. So I wanted to start there. So as we think about, lived experience experts from kind of HVAC's perspective, how does HVAC want to define that? Like what comes to mind for you when we use that word or that phrase, those words or that phrase? Go ahead, Christy.
I immediately think of graduates of those who have been in our program or programs across the state. Who we've worked with, for many years, where we've seen the progress and growth.
Thanks for that, Christy.
This is Marilyn. I agree with Christy. When my first thought is a program graduate that we know, and that you wouldn't want to put someone in this situation where it would be where it could potentially wouldn't be a good fit for them. But I can definitely see graduates who would have so much to contribute to the things that we're talking about here.
It looks like Christy and Marilyn have the same thought around former. Would this definition include current parents or caregivers? Would it or could it? Jessica, could you click through the slide? Let's just click through it all the way through. I think that's it. So these are just some of the questions kind of guide and prompt our conversations. So it sounds like, at least from a couple of things that we've shared, is we're interested in both had of experience accessing the services, home visiting services. Is there any other experience or perspective we're interested in having represented through a lived experience expert?
I just want to add my opinion on like a current client would just be that I think it's really difficult when you're currently receiving services and then we're talking about those services and how to fund them. And I think that could feel really weird and uncomfortable for them. And I think that like it's such a great opportunity for a graduate to have an opportunity to serve on a board, on a committee. But I think it would be difficult. For current.
Thanks for that perspective, Marilyn.
I definitely agree with that. And thinking about a former child participant, how cool would that be? I mean, we're going to be looking 20 years down the line for that. but we have had families where their parents have been in a program and then they choose to be in the program with their child. So, but that's looking at a real longitudinal wait for people to be on the committee at this point.
So it sounds like from those of us who are here that somebody with experience accessing home visiting services would be, go ahead, Marilyn.
I just wanted to throw out a couple of other ideas for
Sure,
people to
please.
respond to. I don't know if, so like a thought I had, like based on our target populations that are in our contracts from DCYF, like, I mean, hopefully in a previous participant, we obviously would hit some of those as well. But I just wondered, would people consider, so, like, for example, someone who'd been involved in child welfare or the foster system, like, would people consider, I mean, maybe they hadn't been in a home visiting program, but they had experience in that system, would that be considered lived experience? Or uh, someone who maybe hadn't received home visiting, but they were a teen parent. I just as a thought, would people consider that lived experience as well?
That's funny, Marilyn, because I was thinking the same thing is that I were doing surveys, and whenever you get people to do surveys, they're usually people that are happy already with your services. So it always feels a little skewed. And I'm wondering if doing active efforts to try to find somebody who didn't do home visiting, but maybe that would have been supportive in finding, and they could share why they didn't, you know, engage. Like maybe they didn't even know it was an option, or this would have been the way that I could have learned about it. But I feel that that's a group we always miss, finding out from them what would have encouraged them to participate.
That's a really good point, Allison, and it gets me to thinking about is on the child welfare side, there are quite a few parents who navigated kind of the dependency process that are actively kind of engaged and involved. So that may be another place for us to kind of look at and to think about potential places to recruit, because it could be good to ask exactly what you were saying. So what were the barriers, and are there, things that we could do about that? And that would be a unique perspective. So I appreciate that. And that's definitely something we should add to the list as we're thinking about places to recruit. Please go ahead, Memory.
Hi, I just have a question about the previous, program participant. Would they be compensated for their time to be able to attend these meetings? Because I know just from firsthand knowledge, when asking to have a community member participate in any type of meetings, their time is extremely valuable and they may not have the resources to be able to sit in this meeting unless it's compensated. And so just something to think about too. And so we always try to compensate or, provide a stipend or honorarium or something, for program participants and community members.
Thanks for bringing that up, memory. I think it's really important to honor of participation and I know Emily's going to be joining us here in a little bit because Emily and I had a conversation kind of about the exact same thing, and I think that was part of the reason we were hoping to kind of structure this alongside and in partnership with community and engagement, because I think they already kind of have a pathway and a structure for that. So that would be something that we would be of interested in exploring. And that may take us a little bit to set up, but I know that it's something that's on their radar at this point. And I do also know that they are participation that we're already kind of compensating for. So I would see that extending to this as well, as we do encourage and want to have participation on, for example, interview panels. We try to have, where possible, parents or caregivers who are actively engaged in home visiting participate. So I think it's important to continue. It's important to compensate, and that I think we would kind of look at what that would entail because it may be structured differently. But yes, that is something that we're definitely interested in doing, and we'll figure out how to have that happen. I think the other things kind of under things that we want to consider is we currently have kind of a set time that we meet for HVAC on a set day, and it's typically during kind of regular business hours. Is it something that we need to kind of look at and consider a variation in our meeting times? Is that so? Just under there are some of the things that I think have come up in of participating, like engaging and having conversations about how best to support engagement as we think about lived experience experts. So just something for the committee to kind of look at and consider. Any other thoughts around the kind of the definition? And definition could also include like what other experiences are we looking for or hoping that individual or individuals would bring to HVAC. And Debs, I see that you are still on, and I was wondering, no, this is putting you on the spot, probably had not prepared for this at all, but Martha shared with us that engaging and kind of identifying and recruiting for lived experience experts for the panel is something that is kind of in your wheelhouse. So is there anything that you could kind of share with us or kind of that would help support where we're wanting to go?
Thank you. I think, a lot of this was really through relationships. So panel members helped us a lot reaching out to find folks with lived experience. A lot of our members with lived experience also have other expertise areas, but there's been times when we have members who that is their primary expertise. But just really getting the word out there honestly seemed to work the best for recruitment for the MMRP in general. This time around, we actually posted on social media, which got us a whole lot more incredibly qualified people than we were expecting, including people with lived experience. So really communicating with your networks, including networks of community-based organizations. I feel like that, I know that's very general, but that kind of summarizes what's worked best for us. I hope that helps.
It does. It does. Thank you. Marilyn, sorry, you were getting ready to say something.
Yeah, it's funny that you said that because that was my thought that I was thinking of and wanting to share, like also thinking about who some of um, each of our community partners are that we work closely with home visiting and that do impact the lives of our families. And I think that fits with what your report shared. Like this is all of us working together. But I think some of the other community partners that we work with closely that we do have a relationship with, they have a unique perspective on the impact of home visiting, and may see families who are participating in home visiting and those who are not. So I think that's a really good idea. And I also like Martha's idea in the chat that yes, we need to get the research arm, another member from the research arm.
I had a question that is very outside of the box thinking here on this, but would it be possible to sometimes have people participate, but they don't have to come to each meeting? So they come a couple times a year or on specific subjects, or they come once and you email out, questions that you're hoping they could answer. Because I was thinking that our new pediatrician would probably be more than happy to be a outside person sharing how home visiting has impacted the family she works with, but there's no way she would be able to, consistently schedule and this amount of time off from seeing patients to be able to attend a meeting. So I don't know if that's a possibility, but I think more people might engage if they didn't have to give up big blocks of time a lot, consistently throughout the year.
I think that's a fantastic idea, Allison, and it allows people to participate in the way that is most effective for them and also for us as we think about different content areas. So I think that's definitely something we should consider and think about. Are there individuals that we also have available that support different topic areas and kind of engage them? And maybe it's like the first meeting where everybody's getting together and getting reacquainted, and then it's, whatever meeting after that best fits their area of expertise. I love that idea. I love that idea. And I think it also aligns really well as we think about the potential of shifting from like subcommittees, like set subcommittees to some topical pieces. So that may be a way to also engage. So I love that. And I think we should put that on as part of what we're looking at. Are there other voices or experience that we're looking for or think would be great on HVAC? So I see, Emily, we were talking a little bit about right before you came on. So thanks for letting us know you've jumped back on. Just about compensation. And I was just sharing with the committee very roughly the conversation that we had around kind of ways to support participation. And I also just shared with the committee that we'll have at least one for sure for June, but it just didn't work out for people's schedules to be part of the conversation today in April. If there's anything you want to share, feel free to either do it in the chat or jump on.
Yeah, I can just share that both of the PAG, Parent Advisory Group members who have a seat on EGLAC, the Early Learning Advisory Council, both of them are interested in coming to share and can like answer some questions if you guys have questions about kind of the setup of dual seats or their experience on PAG or ELAC or any of the above.
So in the follow-up email, I'll ask if there are any questions that you want us to share with the two people who are coming on, just so they have it ahead of time and can be prepared. And then we'll just send a nudge so that we can get that information to them for June. Thanks for that, Emily. So we've had some suggestions on other kind of experience and expertise that we may want to consider. So there was academic that Martha put in, a representation from TANF. Allison shared kind of pediatricians and others who may not have kind of a ability to fully commit to every single meeting, but could be part of topic pieces. Are there other voices that we feel need to be kind of added to HVAC? Thanks for that, Marilyn. Something to consider. So we have thank you, Christy. That's somebody else to consider, child welfare representation. I think that would be great. And we could do that in lived experience, or we could do that from a couple of different angles. So we could explore which one makes the most sense for HVAC, or maybe it's more than one because they have different perspectives. So kind of next step on this is pull together the information that we've kind of shared and talked about, and just kind of loosely put together what we can gather as a definition, and they'll send that up as part of the materials for people to take a look at. We have one last meeting for this state fiscal year in June, but I think we still have some work to do around the recruitment, and so I would say recruitment, kind of engagement, and then really thinking about the structure for subcommittees, if we want to do subcommittees, or if we want to look at kind of doing more small groups, and thinking about that in kind of conjunction with our recommendations and the work that we want to continue to move forward with the recommendations. So in the kind of a conversation with Marilyn and Gretchen, what we would like to propose is to add one meeting either in June, July, or August to focus on just kind of recruitment, and to focus on kind of the structure for the subcommittees. I won't call them that, for the groups, whatever the subcommittees assumes that that's the structure that we're going with, whatever the structure may be for the group work. And so are there, I know that gets into the summer, and summer months are typically, it's hard to gauge and guess which month in the summer is is it less busy? I don't even know what the word would be. And certainly, because I don't know that we're necessarily less busy, but maybe whatever the word is, I can't think of it right now. But between July, August, or September, is there a month that would be better? Because I think we typically start our meetings for the year in September or October. So I think the last 2 years, I think we've done special things in September around rates, I think the last year, but we typically start in October. So July, August or September? Is there a month in there that works better for you as you think about your schedule than others? And you can put that in the chat or you can unmute and kind of share.
I vote July, just because June, right around there, is graduations and end of school year and all of that. And then August, everybody's working on the back to school stuff, and there's a lot of events in August, I feel. But that's just my little world. So I know everybody else is a little different.
I saw some head nods and at least one thumbs up to July. So we can propose that a date in July, and it looks like we did kind of for this last state fiscal year, we did a meeting in July to help support that. So if we follow kind of what we typically do, like our regular schedule, it would be July 16th. Could be a potential date for that. So, and so what we'll do is we'll just put a calendar hold and with our kind of wrap up for the meeting, we'll include that there. And if there are other thoughts or other kind of ideas, we'll ask people to reach back out. And if we end up with, like 3 of us who can be there in July, then we'll kind of figure out a different date. But if we have a significant number that can be there, then we'll move forward with kind of a really structured time. So we'll put together some information and really kind of make some decisions and kind of move forward. The hope of kind of getting everything implemented and moving with SFY 27.
And then would it need to be 3.5 hours? I mean, that's
No,
the other thing is,
no.
if it could be condensed, maybe people would be able to do that a little bit easier.
Yes, I was thinking more like 90 minutes. Because I think that would give us enough time to kind of move through and get some pieces. Because some of it is making some decisions and then really kind of thinking about, so what's a recruitment plan for whoever it is that we've identified, or how do we want to structure? So I think we could do, I think 90 minutes would be enough to kind of make through and get ourselves a plan together for the next state fiscal year. So yeah, definitely not 3 hours. All right. So any other things coming up for any thoughts, any questions, any concerns, any advice over everything that we've covered today? There's that precious face, Mansa.
I did want to mention, this is Marilyn. I know Laura had asked this question and we didn't really have time with the maternal mortality report, but I do just want to acknowledge that I think those recommendations for the HVAC are really important for us to also keep on our to-do list, for the lack of a better term. But I think it's important, maybe that's a big group thing, or maybe that's one of the small work group things to do. But I think that's important for us to look at again.
Thank you for that, Marilyn. I do too, and we'll want us to pin that and think about how we kind of intentionally focus on. And maybe it's not every single one, but the committee can think through which ones do we want to look at or focus on for SFY 27. And maybe that's how we structure our groups or our focus, however we want to term those, what used to be formerly known as subcommittees, how we structure that time. If there isn't anything else, please take time to complete our survey. It was, I think I dropped in the chat earlier by Jessica. I think I just put it in again. And we'll have some follow-up pieces in our email here in the next week or so. And then looking forward to seeing you in June if I don't get a chance to see you before then. I hope that you have a great rest of your week, and thank you again for your engagement and participation today. I will talk to you later. Bye-bye.